Great. Well, welcome everyone. It's a pleasure to be here again at this year's AIS. I had the unique opportunity to be here last year as well. See a lot of familiar faces, new faces, and of course now Ozempic faces. So welcome and great to have all of you here. So we're going to spend the next few minutes talking about, again, with this esteemed panel. And firstly, I'd really like to take a moment to recognize that with having the privilege of speaking in a lot of different meetings, it's quite uncommon to bring together all under one roof. Leaders in pharma companies, certainly representatives of some of the most esteemed financial institutions, and of course, world-renowned faculty that have pioneered and championed all these techniques, and that's all happened here at AIS. So congratulations to Dr. Stevens and his team and co-founders. I'd like to give them all a round of applause, please. So with that said, I'd say that, firstly, below the belt has a tendency to have a negative connotation, right? When we think about our current lexicon of conversational or just in colloquial terms. And for the longest time, there have been a lot of unique challenges in the aesthetic space with having a tremendous amount of innovation in lower extremity contouring. We've seen some nice changes with magnetic muscle stimulation or electromagnetic stimulation of the gluteus maximus and some cellulite technologies, but really over the course of the last 1 to 3 years in particular, we have seen a tremendous amount of applicability of body contouring technologies that can complement or supplant surgical intervention. So it's really amazing to have the group here because I think rather than just talking about any one specific technology, I think we have the really distinct opportunity to talk to this panel about how they're using a lot of combination therapies and most importantly, optimizing patient outcomes. I think when you think about from the audience perspective, what I would love to get from this this portion of our conversation, it's really recognizing how some of these technologies can come together. I think Ms. Van Hove already did an excellent job of sort of stating where the challenges lie. And we'll talk about some of the aesthetic pathology and the unmet needs that we now have emerging technologies being able to solve. So first I'm going to start, really with opening up here with Dr. DiBernardo, colleague that's not too far, almost like a neighbor right across in New Jersey. And Barry, your reputation precedes you as someone who adopts a lot of different technologies, vets them, and then has the ability to figure out what is optimal for your patient practice. So when you think about contouring below the belt, tell me what are the innovative things that you're doing with your patients and what type of combination therapies are on the horizon for you?
Thank you, Sachin, and thank you, everyone. I think what Carol started with the first talk is the problem would be if you think you have one tool to do this because it's many different problems, and it's been said already, I'll just repeat it. And it's not only below the belt, it's above the belt, it's necks. What is it? Skin, fat, muscle, and below the belt we have another additive, which is, so it's all of those. So when we do research on all these, and we probably have every tool to deal with it. So I'm going to pick the best tools to go after. So my advice is look at that patient, define in your mind and with the patient what are the problems. Is it skin, fat, muscle, combination, cellulite, and then pick each tool. And part of that discussion is, okay, do you want to do this non-invasively, minimally invasively, more than that? And so it's a whole matrix of how we discuss this. But fortunately, in 2023, as you're seeing, we've got most of those tools right now, and we can attack all of this pretty well.
Great. Well, we just heard, from the panel, and thank you again to all the panelists from our industry perspective that came in to highlight the technologies that they have. So I appreciate you answering the call whenever you were invited to be part of this. With what you heard about, for example, Avili, and then of course the Viality device, and certainly also with Renuvion, do you use any of those technologies currently in your practice, and how do you like to use them?
Yes, we use the Avili and the Renuvion. When you have the dimples, it's that tough, and it's very, very tough fibers. We use that to release them, and then we can go in with the Renuvion, for example, and then go ahead and tighten that understructure. The video didn't play, but it looks really cool with the helium and sending the plasma. And I've found that that's a very easy tool to cover a lot of area and to get a very good tightening early on. We've worked on a lot of technologies, and usually when you do the skin tightening, it's got a very slow slope over 6 months to see the tightening. We'll see a faster takeoff with the Renuvion, but the message here is if it's a cellulite patient who has loose skin and cellulite, and you use the combination, you're going to get way better results. And the last thing I'll say is, because we've done cellulite studies since 2011, if you think a lot of the technologies or products failed because they were only going after dimples. When you treat a patient, in their mind, they can't go to the beach if you only do the dimples. You have to do everything together. You have to make them whole, and we tell them right up front, with all the technologies, don't think you're going to be 100%. The best we may get is 70, 80 if we're doing really well, but that's usually better. But you need to treat the skin, the laxity, the dermal thickness all together.
Well, I think, and that's where it's really well suited to be looking at the aesthetic pathology of that aging. It affects all the different skin types, and of course also the different soft tissue types with volume loss, et cetera. So I think,
and muscle, of course.
Of course, and recognizing that, releasing that fibroseptal network or the septae, and then tightening it with a different modality kind of leads to optimal outcomes.
Exactly.
Well, thanks for taking us through what you'd like to do in your practice. Next, Dr. Nahai. I mean, we have the ASJ editorial board meeting shortly after this. You've been the editor and are the editor-in-chief of the journal, and have seen a large evolution in cosmetic medicine as a whole. I mean, maybe take us through your thoughts on where lower body rejuvenation and the different types of technologies that you've seen over your illustrious career, if you'd be so kind to maybe give us that perspective.
Do we have enough time?
We have all the time in the world for you, Dr. Nahai.
I've had the joy and the privilege of being able to evaluate numerous papers on modalities that work, those that don't work, and those that are harmful. I consider myself almost like a gatekeeper, because if it's peer-reviewed and if it's in a reputable journal with a high impact factor, approaching an impact factor of 5, people are going to believe it. People are going to trust it. So that's an incredible responsibility for me. I've published your papers. I've published Grant's paper on Healthegy. In fact, it's in the current April issue. So what I have seen is that there is a lot of hype out there. A lot of claims are made that are not fulfilled. But on the positive side, the good news is we have a lot of good evidence that there are effective modalities that work below the belt. If you stand up, actually, your hand is also below the belt. So everything that we have said so far about the hand, about the below the belt, we can say about the hand. So the good news is, yes, the various devices that we have published on work. The one-year paper that Grant Stevens has in the current issue of the journal on Healthegy works. We have papers on Body Tight, on Renuvion, and I was very happy to see that several of the presenters actually showed the logo of ASJ. So we have a lot of opportunities, and we have a lot of choices, as you pointed out. So, and I will always tell the fellows and residents I train, don't believe anyone unless they show you their numbers and their complications. You don't need to be an expert on every machine, every modality. And we're talking about cellulite. There's at least 4 or 5 different modalities. Just become an expert on 1 or 2 and make sure that's what the result you have is what your patients are expecting, because there's too many options there. You have limited time. You don't have endless patients to do this with this patient, this machine for this one. Work with one that you're familiar with. Work with one that provides consistent results in your hand. As I said, I could go on, but the last thing I want to say is that there are procedures in our specialty that I have witnessed over the past, don't tell anyone, 45 years of practice. I used to tell the residents back in the late 70s, become an expert at breast augmentation, you build a practice. And then, of course, 91, the FDA took the and the moratorium. But by then, liposuction had been around for at least 12 years. I said, okay, become an expert at lipo. And it's interesting that consistently either breast augmentation or lipo are number one or number two cosmetic surgical procedures. The advice I have given the fellows and residents the last 4 or 5 years is get involved with genital rejuvenation, get involved with below the belt, and we have one of our fellows just joined our practice, and I said to her, Catherine, become an expert on Aveli, because this is going to be your practice builder and your way to get into this. Today it's working on recontouring the lower extremity and buttocks for them. Tomorrow they'll want you to do blepharoplasty and facelift.
Well said, and thanks for taking us through that perspective. Dr. Harrington, it's a great segue because you are involved with a lot of those clinical trials and the paperwork, and the papers for Aveli and and then have a large commercial use with it, so to speak, on your everyday patients. Would you be so kind of tell us what has been your experience as far as tools or different techniques, or how have things evolved from when you first started with the clinical trial into how you're treating your patients with cellulite, and why do you choose to use one modality over another?
Sure. Well, first of all, just 2 comments. Comment 1 is that I am very grateful to be here. It's been a great day to be surrounded by people, everybody in this room, from industry to colleagues, et cetera. I'm here because when Grant calls and says, you're going to be on a panel, I say yes. And but it's my second time here, and it's been just such a privilege. And then Tahoe, the puppy, really took it down for me, so hopefully he'll be here next year if I get invited. Second comment is, and I know that we can all chime in on this, I'm sitting next to this guy. If you had told me when I was a new plastic surgeon, that I would be on a panel with Dr. Nahai, I would have said, there's no way in God's green earth.
You're making me blush.
I'm sorry. I don't know how, Maze in the High, your flat book. I slept next to that book more than I've slept next to any book in my life. And so I hope that everybody in this room knows what this gentleman has brought to our field. So.
And he's being honored tomorrow, Friday night.
Yeah.
Jen, I think at the oral boards when I opened my, my bedside desk, instead of the Holy Bible, there was a copy of Dr. Nahai's textbook.
Correct.
So I think, yeah. So
right? I mean, honestly. Okay, so the question was, I was involved in the study, which I'm grateful for also. It was a really fun time in the winter of 2021. And interestingly enough, we were FDA cleared fairly soon, quickly. I did a total of 18 patients in that study. And honestly, I had 18 happy patients at the end of it. So then we, journeyed down the path of how was Aveli going to really, fit into my practice and be part of my plan of becoming a pioneer with all of the companies and my colleagues on lower body rejuvenation. And we all know it's not one thing. It's volume, it's cellulite, and it's laxity. And once it was cleared, then I was able to kind of do what I wanted to do with it. And I would then say began the wild, wild west of lower body rejuvenation, because we were all trying all these different things, from injecting Sculptra and fat. And I mean, we were just all out there trying to do the right thing. And, thankful to, good research and papers, then you have to make the decision, well, what are you going to bring into your practice to add on to, cellulite release? And so I will tell you that I do Aveli quite a bit. I've added in Renuvion. Obviously, I've also continued my liposuction practice. And so that's pretty much what I'm doing. I will still do some microneedling with radiofrequency with either Profound or Genius. We're using Genius more at this point. But it's been a journey of really goodness for women. When I think of lower body rejuvenation, in my career, I'm in my 23rd year of practice. We weren't talking about this 23 years ago. We weren't talking about this 13 years ago, really. So I've thought about it a lot, and I thought, well, there was the silent generation, okay, and then there was the baby boomers. Well, they just didn't show anything. The women weren't in really sports at that point. People weren't going to Lifetime Fitness every day. It was just a different time of family, and they were different generations. Well, I'm a Gen Xer, kind of right when all of this sort of started to happen, where women became known athletes. I think of Mia Hamm and, the gal that ripped her shirt off when she won the soccer, brass stain. Brandy, yeah. And then, Lifetime Fitness, and we're women that are much more active, and I think more willing to change ourselves to be our best self. I will tell you, at unfortunately 57 years old, I used to have the best soccer legs of my life. And if you said to me, what is the hardest thing that you're aging with? I wouldn't say my face. I would say it's my lower body. So I think we're on a journey of goodness. I think we're on a journey where Gen Xers and millennials and Gen Zers are all going to be very, very much on board to, prophylactically and currently treat this area, because legs are a very important thing. I think of Carrie Underwood and I think, wow, look at those legs. Well, when Carrie's 57, she's not going to like it unless she figures it out. So I'm a firm believer that we're...
Do it for Carrie.
Yeah, that's right. I think we're on the right path. I think this is a great topic. I'm hopeful to be a part of this whole process. I'm willing to learn with all of you, and I'm looking for any tidbit I can get to. But for right now, it's liposuction, Avali, Renuvion, and some topical microneedling is what I'm doing.
Great, thank you for that. Next, I'd like to credential Dr. Tenenbaum, friend and colleague, has an excellent hybrid practice of aesthetics in the academic setting at WashU as an associate professor of plastic surgery. When you're addressing lower extremity, we just heard obviously from Dr. Harrington the whole, again, the discussion around what are some of the elements of the aging lower body, so to speak. How do you like to address and in what order? If a patient comes in and obviously they have more than just one, we know that lower extremity and below the belt aging is, again, a whole myriad of aesthetic pathology, so to speak, as I like to call it. What do you like to address in what order and why if a patient can't just do it all?
Well, I think that the way I think about it, so we're all allergic to unhappy patients, true anaphylactic to unhappy patients. So when I think about their concerns, and we've all talked about Carol's great presentation, it was so true. Women, we heard that the number one complaint is cellulite, but when women say cellulite, what they mean is all of these things in combination, and almost all women have all of these things in combination on a severity scale. So I try to make sure that the patient feels heard, and then I like to address it kind of in order of what I think I can get the biggest improvement with. So for example, if there are excess pockets of fat, liposuction is still going to be the gold standard, and we're going to use that for contouring, plus minus some fat grafting to help the overall contour. True dimples, Avali has been amazing and a game changer for true dimples. But I try to be very visual with the patient and explain to them the dimple that can be corrected versus what you think is a dimple, but it's really laxity, and maybe that's going to be lower on the list. The other modalities for skin tightening, Renuvion, ultrasound devices, hyperdilute radius, all those sorts of things can certainly help, but especially in the Midwest, we still are a long way away from really being able to bring home runs for patients in that arena. So that's probably the area that I promise the least. So I would say that's kind of how I order it, what I think I can make the biggest difference in, and then go from there.
Excellent. Dr. Hustek, you have a wonderful practice and a large volume of treating this area, in particular with the buttocks, and also what I'm hearing with what Dr. Tenenbaum was talking about with respect to sort of almost like fat redistribution, right? Sort of rob Peter to pay Paul, so to speak. Yeah. How do you incorporate fat transfer in conjunction with cellulite release in your practice for your patients, and is it basically almost like mandatory? Is it something that in a perfect world you want to do all the time, or is it just on a case-by-case basis as far as combination surgical modalities?
Yeah. I didn't think we could escape being in Miami, not talking about butts today. So I'm glad we were able to get this in. No, I do a lot of BBLs in my practice in southern, the states down in Houston, just like Miami. And it's an interesting demographic, right? Because they're looking at their booty all day long. And so this is really, and we know with fat transfers that it's a totally different plane, that it oftentimes does not improve cellulite. And if you look through some of your old, your own patients and look critically at it, the cellulite was identical, even with some volume increases. So it doesn't improve cellulite, and we have big conversations with patients because that's usually what they come up back with, that they love their volume, but why do they still look dimply, right? Because it's an education gap. And so I think the only time I do cellulite releases ovally standalone is on my old BBLs, and they're my happiest. They're like, oh my gosh, finally I have something that just smoothed it all out. So they've been the happiest. I do incorporate it now pretty consistently with most of my BBLs because the majority of them do have some cellulite dimples as well, so it'll really just smooth out the results. I think it's been much easier with the new ultrasound-guided deep plane fat injections. When I first started it, it was a little bit of a mess. If you fat grafted first and then did your releases, you get herniation of fat into those planes, and that was a disaster. You had to go back in and equalize it. So then I started doing the fat grafting first, and then when you went to do the releases, fat was egressing out of your access site, so you'd have to do a separate access site. So it was just playing with that. But now that we're in a deep plane, I'm releasing ovally at a totally different, the superficial fat compartment. So I'm nowhere near it, zero fat egress, same access incision. It's been fantastic. It adds 10 minutes as a multimodality. Selling it is a little bit different. Some of those patients are very price conscious. So when you ask them to add on a certain amount, there is a good subset that says, oh, you told me I can just do that later. If I don't like it, fine. So I do have a subset of patients that are like, I see what you're saying. I see the problem. Finances are an issue. If I can do that later, awake under local, fine, let's just consider doing that then if I'm not happy. So that's kind of how it's been incorporated in my practice from a fat grafting standpoint.
Great answer. Dr. Tenenbaum, you have a very large practice with a lot of breast aesthetic and reconstructive breast surgery. When you're counseling a patient on fat transfer or fat grafting to the breast, what are the typical sort of retention rates, or how do you counsel those patients? And how does the new entrant of something like Viality, with preliminary data from the studies that I'm involved in and just in general that our colleagues are, that are showing up to 80% retention at 3 to 6 months, what does that confidence look like, or what does that feel like to you?
It's a really good question. I think the conversation with patients is that, our current sort of avenues for fat grafting is widely variable based on the patient's biochemistry, based on your harvest technique, based on your injection technique, all of those sorts of factors. And so, I am very honest, and I tell them I can't give you a really accurate answer on how much fat will be retained. It's a big range, anywhere from maybe 30% to 80% is going to be maintained. One thing I know for certain is we're not going to keep all of it. That's the one thing we know for certain. So I think with newer technologies, cleaner, healthier fat, better transfer systems, hopefully we'll be able to get a tighter range on that for patients' expectations.
Great. And Dr. Harrington, you were earlier talking about other modalities to also address the skin itself with some of the microneedling with energy-based devices and technologies. How do you decide when, for example, if we're using like the Renuvion device where it's tightening the fibroseptal network and working from below the dermis and in that superficial fascial system, when do you decide to incorporate that technology versus sort of addressing the dermis from a percutaneous perspective with an energy modality?
That's a really good question. So I just obtained Renuvion in December of 2022. So I was a late adopter, but a happy adopter. I'm pretty much using it on every liposuction case I'm doing, almost every single case. I think there's a place for both, but money doesn't grow on trees for people. So I think those are conversations to have with the patient. And I'm all about bang for buck too. So if I don't think they need it, any of it, even the whole operation at large, I'm like, I think you should go to Cabo and not have surgery with me. So I think Renuvion with liposuction makes sense all day long for really anybody over the age of 40, I think. But then if you're going to add on and encourage a patient to maybe go with a dermal microneedling device with radiofrequency, I think it depends on the texture of their skin. I find that if we're going to kind of go mid-body and down, it has to do with the actual literal texture of how we get that crepey skin around the belly button postpartum, how we get that crepey skin on the inner thighs because the skin is thin. So if they have that and we talk about it, and that is a component of their laxity, I will encourage them not to break the bank, but if they can afford it, it makes sense to add it in. So.
Dr. DiBernardo, if you'd like to comment.
Yes. I'm going to say something similar. We have a protocol for that, and that is if we make the distinction between tightening and wrinkling or crepiness. So think in levels. If they have loose skin, we'll use our tool of choice for tightening, like Renuvion. But if there's wrinkling in that skin, that's where we'll, if you want to do it scientifically, we measure with ultrasound the thickness and then set your RF microneedling to that level to mid-dermis. So you're hitting, they're actually two different problems. So you can use both tools. Not so much in the lower extremity. We do this in the neck a lot with the neck procedure we do, my Elevate. So if we're almost always doing tightening, but if they have wrinkles in the skin, then we'll overlap and do 3 microneedling treatments starting the time of surgery and then 2 more. And then we do a little add-on to the procedure for those 3. But tightening versus wrinkling, crepiness are 2 different problems, I think.
I totally agree.
Dr. Harrington, go ahead. Yep.
Yeah, and just real quick, so I'm my own little experiment now that I have Renuvion. So I've done my right leg, and I'm bringing back FloJo, and I've done Genius on my right leg twice now, and Renuvion once. And so hopefully maybe next year I can share what that looks like.
May I just ask what you have against left-handedness and left legs? I mean, why?
I know, I don't know. But I had really both those problems. That's the point. It's this levels of lack of laxity,
Just know that if you're going to pick the hardest area to do, it's a knee or that leg skin. And what I fear is when patients come in and they do the pull up the leg skin, because we do research on tightening all the time. That's what we're going after. That is the hardest, the anterior thigh and knee.
And that's what
The first thing I say is you have to stop doing that because we're probably never going to get there.
That's right. Get your hands off of it.
Stop doing it.
Dr. Nahai, just wanted to come back to you and ask, with all the different technologies and you having had the practice you had for as many years as you had, what are the challenges that you feel are present in incorporating devices or technologies? Like, for example, we see that there's some great data preliminarily with the Soliton device. I'm certainly excited about a technology that could help address in a non-invasive pretty much a non-invasive way for cellulite. But what is it that you look for when you're looking at a cost-benefit analysis of incorporating novel devices and technologies into your practice?
Consistency, effectiveness, and cost. I think the two of you both mentioned they don't want your patients to break their bank. And I think as in private practice with machines, we don't want to break the bank. And forget it if you're an academic institution, and I've been in and out for 27 years, they're not going to buy you any machines. No. The only thing that helps us in Atlanta, and I'm sure it's true elsewhere, there's a company that brings in the machine into your OR just for the one-time use. I recall in the very, very early days of radio frequency, Rod Hester, my then partner, felt that we'd fall behind if we don't offer people non-invasive facelifts. I said, I'm doing enough, I'm happy. No, they're going to go elsewhere. So we acquired a very expensive machine. In fairness to radio frequency, it was in its infancy. It really didn't work. It disappointed our patients. More of his than mine because I was strict. But we both ended up doing discounted or freebie facelifts because we had disappointed patients. So I talked a little earlier about what I tell the residents and fellows of practice builders. I also have the negative one. What will destroy your practice beyond how you and your staff treat your patients, how you return calls, etc. is procedures that don't work, procedures that overpromise and underdeliver. And in my experience, very early in the radiofrequency days, that was the issue. Today, I do use liposuction and radiofrequency. I use a different machine to the Renuvion, to the Apex. But whatever works and whatever is affordable, we have one unit in the office. In the hospitals, we have somebody bring it in, because I don't think any practice, forgive me, other than his, where you're evaluating everything, can afford to have every single machine. So the best advice is figure out what works. And also, somebody earlier said, if you have just the one machine, then you're going to recommend it for everyone. You try it on every one of your patients. The best thing is one-time use technology, and there's several of these. Aveli comes to mind immediately. It's one-time use. You don't need to buy a machine. You don't need to rent it. And those are the financial decisions that have to be made in practice, that for those of you in industry, we can't afford to buy 5 or 6 different machines. No practice can afford it, because with most of them, the technology is still evolving, and what's good today reminds me of the early days of computers, that I had to change one almost every 18 months. I now have 3 of them that have worked beautifully for 5 years. So excellent point both of you made about not breaking the bank. I don't think we can break our own bank, and forget academics. They're not even going to buy you the first machine.
Yeah, they bought me a couple.
Well,
You must be more persuasive.
very well said, and I think in the interest of time, I'd like to kind of close out this session. What I took away certainly is understanding that certainly lower extremity contouring below the belt is a multifaceted pathologic process that requires really a lot of the modalities. And when we heard about some novel technologies on the horizon, like our Soliton, to be able to address that, gets me really excited. And then certainly the 3 devices that are already in our practices and that we're able to use right now really give us the opportunity to optimize fat redistribution, tighten the fibroseptal network, and improve texture and quality of skin, and also a very focal release with the Aveli device in a one-time use type of technology, which is, again, doesn't break the office bank, but can also optimize patient outcomes. So thank you all very much, and appreciate the panel being here. Thank you.
Great.